Good evening, everybody. Welcome to this evening episode of Pursue. And today we have Pursue 10D, which is breast pathology, and we are streaming live from YMCH Mangalore via Kolkata. And today we have a special topic and a special person to talk on that. We have Dr. MADAN K, who is an MD Path, a DNB, and a PDF in Oncopathology from Bangalore. He is an assistant professor in oncopathology in the Department of Oncology in Yenepoya Medical College and Hospital, Mangalore. He's got multiple publications in international and national journal. And he will be talking on something which is the hot topic of this session, which is molecular profiling of breast carcinoma and rare subtypes of breast carcinoma. And before I ask Dr. Madan to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Madan. Sir, please share your screen and start the presentation. Thank you.
Yes, sir. Thank you, sir. Just a minute.
Just press present now.
Yes.
Yeah, I can see your screen. Please make it full screen.
Thank you, sir. Can you hear me, sir?
Absolutely fine. Yes, I can hear you clearly.
Yeah,
Please start.
Thank you, sir. Thank you for the introduction. In this lecture, I'll be covering two topics. The bulk of the talk will be on molecular profiling of breast carcinomas and a few slides about rare subtypes of breast carcinomas. To start with, breast cancers are heterogeneous and they show variable morphological and biological features, and they have a different clinical behavior and respond to treatment differently. So hence, cancer classification in general aims at an accurate diagnosis and prediction of behavior, so which in turn facilitates decision making in the field of oncology. Breast cancer, just like any other cancers, is categorized by clinical stage and pathological subtype. So by categorizing based on this, it correlates with the survival data, predicts natural history of disease and treatment response, and also is fundamental in therapeutic decision making in the field of oncology. So traditionally and till date, this is how the breast cancers are classified based on their histological features and also the stage. But in this era of personalized medicine, is it good enough? The answer is clear no. This is because even though these methods are standard for classification, they are relatively crude, and clinical staging and routine pathology are considered principal indices for adjuvant chemotherapy. So by doing so, like we are over-treating a significant number of patients. So there are multiple studies, many randomized controlled trials, and what they say is there are a group of long-term survivals even in the untreated arms, and the other arm which showed some patients, in spite of adjuvant cytotoxic therapy, developed metastatic disease. Hence, the clinicians now, they clearly lack a marker which predicts which of the patients will benefit from chemotherapy and which will not benefit from chemotherapy. So it is essential to understand the biology of the tumor to understand or to answer the previous question. So this is where the molecular profiling comes into picture. So molecular profiling allows tumors to be defined by the expression pattern or genomic alteration of thousands of genes simultaneously. So the technique comes with the prospect of defining individual genes or like combination of set of genes whose expression level can discriminate efficiently between the clinical subtypes. So recently, gene expression microarray has been used extensively to study the tumor subtypes. So this is the slide showing the historic events in the field of breast pathology. So if you look here, so it all started in the year 2000, which was the breakthrough year in the field of molecular pathology of breast, where Perot et al. Divided the breast tumors into 4 molecular subtypes. And a decade later, we had multiple prognostic signature assays, so which will be discussed in subsequent slides. So as I mentioned, the year 2000, Perot with his colleagues were the first to use gene expression profiling to stratify breast tumors into molecular subclasses. They found out that the tumor showed great variation in their pattern of expression, and this variation was multidimensional. So this is a slide showing the results of their study. And finally, what they concluded was they derived at two distinct molecular classes, that is ER positive cancers and ER negative cancers. ER positive cancer being the luminal type, ER negative being the ER negative group consisted of HER2 positive, basal-like and normal breast-like subtypes. And a year later, the same group led by Peru et al. Subclassified the luminal group into luminal A and B. So at this point of time, by now we had classes like luminal, which is subdivided into A and B, normal breast-like, HER2 enriched, basal-like, and Claudine type. So these are the various molecular classes at this point of time. So also we should know why is it important for us to classify breast tumors based on their molecular behavior. So by doing so, it helps us in the diagnosis, to assess the prognosis, and also to predict the natural course of the patient following treatment. So for molecular classification, there are certain set of ancillary techniques. So the most commonly and widely used being IHC, and then we have FISH and gene expression assays, either by comparative genomic accreditation, gene expression microarray, or quantitative PCR, and finally the NGS. So with these available ancillary techniques, this is how the breast cancers can be classified. So based on histology, they can be divided into invasive carcinoma (NOS), and then we have the special types. So based on the IHC markers, they can be divided into ER positive, HER2 negative, ER positive, HER2 positive, ER negative and HER2 positive, and ER and HER2 negative. Based on gene expression levels, we have subtypes like luminal, which is subdivided into A and B, HER2 enriched, basal-like, Claudine low, and few minor groups. So NGS is used to assess the multiple genomic aberrations. So if you look here, these are the various circus plots. So this is one circus plot which is of a luminal A type of breast cancer. So if you see here, there are hardly any lines between the circle. So what it indicates is, what they say is luminal A group of tumors are genomically simple. So there are very few genomic aberrations in luminal A type of breast cancer. If you compare it with the basal-like breast cancer, if you see this is a circus plot of basal-like breast cancer. There are multiple green and red lines here. So each line indicates the genomic aberration. So basically the basal-like cancer is genomically complex and shows multiple inter and interchromosomal aberrations. And currently, with the molecular profiling, these are the various types of classifications and subclasses is what we have. The intrinsic subtype classification, and then the integrative clusters classification, and then the triple negative group has been subclassified, and then we have mutation profiles in invasive breast cancer. So we'll see one by one. So this is the traditional intrinsic subtypes as mentioned by Peru et al. And with the available IHC markers, that is ER, PR, HER2 and Ki67, these IHC markers act as surrogate to arrive at these intrinsic subtypes. However, with the invent of high throughput techniques like DNA and RNA sequencing, we have integrated clusters which have been identified as from 1 to 10. And then again, as I mentioned, the triple negative group is subtyped or subclassified into various types like by different groups. So, but the two well-known groups are Burston et al. One by Burston et al., which includes both genomic data and transcriptome data, and they classify the triple negative group into 4 groups. And similarly, Lemon et al. Also classified triple negative breast cancer into 4 groups, but he used only the RNA sequencing data. However, there is a significant overlap between groups, overlap between both the groups. So this is a table showing the details of intrinsic subtypes. We have luminal A, which shows expression of ER, PR, and which is negative for HER2, and this is the most common group, and which constitutes for 50 to up to 50% of cases, and this have a favorable prognosis. And these groups are treated only with endocrine therapy. And then we have luminal B subtype, which is again subdivided into HER2 positive and HER2 negative. And this is the second most common group. And histologically, these tumors are of grade 2, and they have an intermediate prognosis. And these tumors are treated with both endocrine therapy and also chemotherapy. And then we have a HER2 positive group, and histological they are of grade 3, and they have a poor prognosis. So one good thing about this group is they have a patient with this group have a benefit of targeted therapy with trastuzumab. And then we have a triple negative group, which is a difficult group to treat, and these tumors are again grade 3, and these are treated with chemotherapy. And also these tumors, however, are chemosensitive. And triple negative cases, whenever associated with BRCA mutations, the patients always have a option of treatment with inhibitors, that is olaparib. So this is the diagram showing various IHC markers like ER, PR, HER2, Ki67, CK5/6 and EGFR, and which acts as a surrogate and subtypes the various intrinsic molecular classes. Then moving on, we have integrated clusters. This was developed to capture genomic aberration-driven changes in the breast cancer, and the metabolic group integrate with an integrated analysis of 2000 breast cancers on genomic expression profiling and genomic alterations arrived at this integrated clusters, and they divided the breast cancers into 10 groups, that is from 1 to 10. So each group has a distinct copy number aberrations and gene expression changes. So this is a busy slide which shows the intrinsic subtypes on this side and the integrated clusters here. So if you see here, luminal A group has integrated clusters 2, 3, 4, 6, 7, 8, and each of these have different DNA changes, and also they differ in the prognosis. And if you see here, the luminal B group has different integrated clusters like 2, 5, 6, 9, and if you see HER2, and this group has an integrated cluster 5, which also is seen in luminal B group, and both of which have HER2 amplification and have a poor prognosis. And then finally, the basal-like, which is a genomically complex group, had integrated cluster 10 and also showed 5q loss, 8q gain, and so on. And basically, there were high genomic alterations in this group, and this group has a poor prognosis. And then coming to triple negative breast cancer, this again is a heterogeneous group, and this can be roughly divided into basal and non-basal. And this group constitutes for up to 10 to 15% of sporadic cases, and by definition, they are negative for ER, PR, and HER2. There are certain set of characteristic findings in triple negative breast cancer, like these tumors are usually of high nuclear weight and high proliferative disease, and there is frequent abnormalities of TP53 and BRCA1 gene. And these tumors, even though they are chemosensitive, they have a poor prognosis, and the peak risk of recurrence is between 1 to 3 years after diagnosis. As I mentioned, this group is again heterogeneous, and based on the genomic expression and DNA and RNA profiling, this group has been subdivided by different groups. The one, as I mentioned, by Lemon et al. Uses only genomic expression, and they divided the triple negative group into 4 types, that is BLA1, BLIS, luminal androgen receptor, and mesenchymal-like. So if you see here, in the basal-like immune activated group, there is upregulation of immune for cytokine related genes, whereas in the basal-like immune suppressed, there is downregulation of the same set of genes. And in the luminal androgen receptor group, there is increased androgen receptors and estrogen steroid receptors also. And coming to the Burston et al. Classification, which was based on both combined RNA and DNA profile, so which divided triple negative cases into basal-like 1, BLIS-like 2, mesenchymal, and luminal androgen receptor. So there was a significant overlap between both the groups. So why is it important to subclassify the triple negative breast cases? As I mentioned, this is a heterogeneous group and difficult to treat. So now with the subsequent or subcategories in triple negative group, we know that these subclasses have a different prognosis and certain groups can be targeted. For example, if you see the basal-like immune activated and basal-like immune suppressed have a different prognosis. For example, basal-like immune activated has a favorable prognosis and basal-like immune suppressed has unfavorable prognosis. And coming to targeted, if you see here, the luminal androgen receptor group has androgen receptor which can be targeted. So it is essential for us to subtype these triple negative breast cancers to give a benefit of targeted therapy in few of the patients at least. So these triple negative breast cancers or basal-like cancers have certain histological findings, such like they are of high histological grade, solid architecture, pushing borders, stromal lymphocytic infiltrate, high mitotic rate. They have medullary-like features, and they have little or no associated DCIS. And then moving on to the non-basal-like triple negative subclasses. So these are the less known subtypes, and this Claudin low subtype is sorted from the triple negative group, and this constitutes for up to 7 to 40% of breast cancers. And here there is low expression of genes related to tight junction and cell adhesion molecules like Claudin, Occlin, and Ecatrin. And here what we see is there is enrichment of EMT, stem cell-like, and tumor-infiltrating-like genes, and there is low expression of luminal genes, inconsistent basal gene expression, and high expression of lymphocyte and endothelial markers. Moving on to the other less known subtype, that is interferon-rich subtype, and these are characterized by overexpression of immune response genes, and this has the best prognosis among the triple negative breast cancer types. So this is a flowchart summarizing the molecular classes what we currently have. So overall, breast cancers can be divided into luminal and non-luminal. Luminal again is subdivided into luminal A and luminal B. Luminal B based on HER2 expression is subdivided into luminal B HER2 negative, luminal B HER2 positive. And coming to non-luminal, this can be divided into HER2 positive and triple negative. Triple negative, as I mentioned, it's a heterogeneous group and is again subdivided into basal and non-basal. Non-basal consists of lesser known subtypes like interferon rich, claudin low, and metaplastic breast cancer like. So all these subclasses have a different prognosis and outcome. So moving ahead, so now we'll talk about multi-gene prognostic signature assays. So what are these? So these are the assays which combine or which check for the expression of genes which are related to cancer, and based on the gene expression, there is a scoring system which is developed. So based on the scoring system, the cases are divided into low risk and high risk. We'll see how it is done. So these are the various set of examples of multi-gene prognostic assays. The most commonly used one being Oncopath and the other important ones being PAM50 and EndoPrint. So MammaPrint and Oncotype DX being the first generation assays, PAM50 and EndoPrint being the second generation ones. So when we are talking about gene assays, we should know like there are certain questions to be asked before asking for such assays. So we should know when to ask for these assays. So basically, these assays are used to assess whether the patient will benefit from additional chemotherapy or he will not. And also, many of these assays are used to assess the risk of recurrence. So most of these, all of these assays are used in a ER positive, HER2 negative, and a non-negative tumor. So these are the tumors where we have to consider asking for multi-gene prognostic assay. So also one important thing what we have done is financial condition of the patient, because most of these assays are quite costly, and also these are not covered in the insurance in Indian setup as compared to the Western countries. So coming to Oncotype DX, both Oncotype DX and MammaPrint have been FDA approved, and Oncotype DX is incorporated in many of the management decision models like NCCN guidelines and St. Gallen's criteria. And both of these have been recommended by ASCO and ESMO as an useful diagnostic tool with additional information to complement the pathological reports. So this is about Oncotype DX. This is a 21 gene signature assay, and based on this 21 gene signature, there is risk of recurrence score is calculated. So of the 21 genes, 16 are related to cancer and 5 are the reference genes. So these are the set of cancer related genes, and these are the set of reference genes. So with the gene expression, the scoring system is derived, which is scored from which scales from 0 to 100. So based on this, the patients are categorized into low risk, intermediate risk, and high risk. So this is the older scoring system. However, currently used is this: the low risk being less than 10, intermediate risk between 10 to 25, and the high risk being more than 25. This has been based on the recent study, recent trial of Taylor X. Coming to clinical implications, this predicts the benefit of adding adjuvant therapy in addition to the tamoxifen, and these also predict recurrence in patients who have had a local excision. So there are multiple randomized controlled trials. The most common and the well-known one being the Taylor X, and this has mentioned that Oncotype DX has a favorable outcome and can be used in both treatment and prognosis. So this Taylor X considered only tumors of ER positive, HER2 negative, and node negative tumors, and the updates of which are available now. And the other randomized controlled trial is RX Ponder, which considered ER positive tumors, HER2 negative tumors, and 1 to 3 node positive tumors. So the results of which are still awaited. And the second one being MammaPrint, it's a DNA microarray based test where which measures the expression of 70 set of genes. So based on this gene expression, prognostic score is developed, and the patients are categorized into low risk and high risk. Coming to clinical implications, the prognostic in both node negative and node positive patients in predicting distance recurrence. And also, as I mentioned, in patients at high clinical risk, this is used for decision making regarding the adjuvant treatment, that is adjuvant chemotherapy along with the tamoxifen therapy. And there's one randomized control trial to validate this MammaPrint, that is a MINDAD, and this is found out that this test can be used only for prognostic purpose, not for therapeutic purpose. And coming to PAM50, this is the RT-PCR based assay, which checks for the expression of 50 cancer-related genes and 5 positive or normal control genes. And here, risk of recurrence is calculated. So as I mentioned, clinical implication being the risk of recurrence score, which is estimated by multiple reference lab, and this risk of recurrence is comparable with that of Oncopath. And currently, it is being validated for postmenopausal women with ER positive, node negatives, or even node positive diseases. And next we have EndoPredict. This is again an RT-PCR based assay, and this measures 8 tumor-related genes and 4 control genes. And these are the various set of tumor-related genes which are included in this assay. And based on this gene expression, an EP score is calculated, which ranges from 0 to 50. So EP score of less than 5 is designated as low risk, whereas EP score of more than 5 is designated as high risk. And then when you're talking about EndoPredict, there is something called EPCLIN score also. So EPCLIN score is calculated by adding clinical data such as tumor size and nodal status to the EP score. So this score, that is EPCLIN score, predicts the likelihood of 10-year distant metastasis in women with ER positive HER2 negative breast cancer. And this also is used to identify tumor that will benefit from additional chemotherapy. So this is this table summarizes the most commonly used multi-gene signature assays with the variable number of genes analyzed here, and Oncopath and MammaPrint being the first generation assays, both being approved by ASCO and ESMO, and the other two being EndoPredict and PAM50. And these are the various scoring systems in the multi-gene signature assays mentioned in the previous slide. So if you see here, the scoring system varies between invasive and in situ carcinoma. This is the scoring system for Oncopath. You see the cutoff is different for invasive as well as compared to the in situ carcinomas. And moving ahead, so one new assay what we have in our Indian setup is CanAssist. So this is an IHC based assay, and this is developed by an Indian company. It's a Bangalore based company. So here, like along with the IHC markers or expression of IHC proteins, clinical condition of the patient is considered and a scoring is derived. So here the scale ranges from 0 to 50 and the cutoff is taken as 15. So score less than 15, the patients are said to have a low risk for recurrence, whereas a score more than 15, the patients are said to have a high risk of recurrence. So in compared to all the other previous multi-gene signature assay, this can be cost effective and can be applied in a routine practice. Moving ahead, coming to NGS. So this is a test with which tests multiple mutations and or other genetic alterations and with timely results. So certain mutations such as PIK3CA, HER2 and ESR1 have been identified on NGS in breast cancer. And this is also used to identify the inherited mutations such as BRCA1 or BRCA2 and also other less known mutations. And this is an ideal tool to detect homologous recombinant deficiencies. So as I mentioned, with the NGS, there are certain set of mutations which have been identified. We should know why and how is it important. For example, if you see, as I mentioned, these PIK3A mutations which are seen in significant number of luminal A types. And also basal-like, if you see, this is a genomically complex group with high TP53 mutations, and it is found out that this group shows copy number deletions in BRCA2, MDM2, PTEN, RB and TP53 mutations. Similarly, luminal AR group also has a significant number of PIK3CA mutations. So why is it important is, even though these mutations are seen in small number of patients, by identifying these mutations, we are giving additional benefit to the patient of targeted therapy. Yes, these PIK3 mutations can be targeted with a drug called alpelisib, and similarly, this BRCA1, BRCA2 mutations can be treated, or patients with BRCA1, BRCA2 mutations can be treated with PARP inhibitors such as olaparib. Also, NGS can, as I mentioned, can be used to detect familial syndromes such as BRCA1, BRCA2 mutations, and these are the widely known mutations already, and there are less known mutations such as or less known syndromes such as Peutz-Jeghers syndrome, hereditary diffuse gastric cancer syndrome, and ATM or ataxia telangiectasia syndrome. And also, when you're talking about multi-gene prognostic signature assays, now there are certain prognostic scoring systems. The two well-known ones are the Nottingham Prognostic Index and the Adjuvant Online. So these are online scoring systems which uses clinical parameters such as age, stage, ER status, and also the tumor grade. So these algorithms can guide the treatment decisions in many of the cases. So this has already been covered. So with all this molecular profiling and molecular classification. So are we ready to use this in a clinical routine? So this is one recent article which was published in the early 2020s. So what they say is molecular profiling can be used in four ideal conditions. That is in early luminal breast cancers. That is in early luminal breast cancer, we can ask for multi-gene prognostic assays and assess if the patient is or if the patient will benefit from additional chemotherapy or will not benefit from additional chemotherapy. And also this can be used to assess the risk of recurrence. Similarly, this profiling can be used in genetic testing in hereditary cancer syndromes like BRCA and BRCA2 syndromes, also the less known syndromes which I mentioned in the previous slide. And molecular profiling can also be used in triple negative cases to subtype and also to identify the targets. Whereas in advanced breast cancer, where there is a limited option of treatment, so it is important because there are certain mutations which have been targetable mutations which have been identified, such as NTRK3 and also the PIK3 mutations. So such patients where there are limited options of treatment, so we can go ahead with these targeted therapies. So with all these molecular classes, classification, molecular profiling, and so where do we stand now? At least in our setup. So currently, all the breast cancers we ask for ERPR, HER2, and Ki67 routinely, and these are the major drivers for clinical decision. And also, these are even though not accurately, these are still considered as a surrogate for intrinsic subtypes. But given the option for systemic therapy, whenever possible, like keeping the financial condition of patient in mind, so we have to ask for multi-gene signature assays. And like, are we starting? Are we treating the triple negative, or are we subclassifying the triple negative group as of now? That is not being done. But there are studies and ongoing projects which are subclassifying the triple negative group, and NGS as a routine clinical practice may be a possibility in near future. So coming to the second part of the talk, that is rare subtypes of breast carcinomas. So the term rare subtype is little subjective here because the most common carcinomas of breast being invasive duct carcinoma, and then we have special types. So what I'll do here is I'll limit my talk only to the new entities and also the rare and cellular gland type tumors. And there is a new sub classification mentioned here in the new WHO, that is exceptionally rare types and variants. So I'll be talking about the new and newly added entities such as mucinous cystinoid carcinomas, tonsil carcinoma with reverse polarity, and few of the cellular gland type tumors and exceptionally rare types and variants of breast carcinomas. So first one, mucinous cystinoid carcinoma, is an invasive carcinoma which is characterized by cystic spaces as shown here. These are the cystic spaces, and tumor cells are arranged in papillary fragments. And these tumors resemble pancreatic ovarian serous cystinocarcinomas. So going to the higher power, we can see here the tumor cells are arranged in papillary fragments with fibrovascular core, and the cells are columnar and the nucleus being basally arranged. What also we can notice here is the cells have abundant intracytoplasmic mucin. So on IHC, these tumors are typically triple negative. The second entity is tonsil carcinoma with reverse polarity. So this is again a very rare variant, and this entity shows overlapping features between solid papillary carcinoma, papillary DCS, infiltrating epitheliosis, and invasive papillary carcinomas. So approach to papillary neoplasms of breast has been dealt in detail in the previous topic by Dr. Swati. And these tumors were originally designated as breast resembling the tonsil variant of papillary carcinoma thyroid used to be in the year 2003. And there were various other terminologies which are used for this entity, such as solid papillary breast cancer resembling tonsil variant of papillary thyroid neoplasm, tonsil variant of papillary breast carcinomas, solid papillary carcinoma with reverse polarity. So these are the various terminologies which were used for this entity. Coming to histomorphology, these tumors are the tumor cells are arranged in circumscribed nests, solid pattern, and some cribriform pattern, and these nests are separated by dense fibrous stroma. When to higher power, what we can appreciate is these tumor cells also show some true papillae with fibrovascular core and some foamy macrophages within the papillae. And also there are multiple cystic spaces as seen here and here, and at places the cystic spaces also show colloid-like material. Moving to the nuclear features, as mentioned, nuclear features are typically here because nuclear features resemble that of tonsil variant of papillary carcinoma thyroid as seen here, except for the reversion of polarity, which is not seen in tonsil variant of papillary carcinoma thyroid. So coming to IFC, these tumors are negative, that is, they are negative for ER, PR, and HER2, and they are positive for CK5/6 and CK7. And the most defining feature of this entity is the most tumors are associated with ITS2 mutations at this spot, R172 hotspot, and this mutation is highly sensitive and specific for this entity in breast carcinomas. So this is one recent case report published on tonsil carcinoma with reverse polarity. This is from Kidwai Memorial Institute of Oncology, Bangalore. And then we have secretory carcinoma. This is also placed under rare and salivary gland type tumors in breast cancer. Here the cells show intracytoplasmic secretory vacuoles and they have extracellular eosinophilic bubbly secretions. And these are frequently associated with ETV6-NTRK fusion. And this tumor constitutes for up to less than 0.05% of all invasive breast carcinomas. So this ETV6-NTRK fusion is also seen in many other tumors, if you can recall, but in breast it is seen only in secretory carcinomas. So pathogenesis, these tumors are characterized by translocation 1215, which corresponds to fusion of ETV6 and NTRK, which is thought to be an early event in tumorigenesis. That means this fusion is seen in both in situ as well as in situ invasive carcinomas. So genomically, these tumors are quiet, that is, they have a very low mutation burden. So this is a fish photograph of ETV6 break-apart probe. Here you can see those abnormal break-apart signals. Coming to histomorphology, tumor cells are arranged in microcystic spaces, tubules, and also in papillae architecture. So here we can record those intraluminal secretions, and these are the photographs of one of our recent case of secretory carcinoma, which also was triple negative. However, FISH for ETV6-NTRK was not done in our case. And going ahead with exceptionally rare tumors, which are still considered as subtypes or is still considered as a spectrum of differentiation in invasive breast carcinoma (NST). They are oncocytic, lipid-rich, glycogen-rich, clear cell, and sebaceous carcinomas. As I mentioned, these are exceptionally rare, and there is insufficient clinical data or evidence to designate them as a special subtype. So these are still considered as patterns, vast spectrum of differentiation in an otherwise invasive breast carcinoma (NST). Oncocytic carcinomas have abundant eosinophilic granular cytoplasm, that is because of high mitochondrial levels. So clinically this is not a distinct entity, but this has to be kept in mind because this is an important differential for apocrine carcinoma. This is a photograph of oncocytic carcinoma where we can see those nests of oncocytic cells with abundant granular cytoplasm. IHC wise, these tumors are positive for anti-mitochondrial antibodies. Then we have lipid-rich carcinoma, but by definition they have abundant cytoplasmic neutral lipids which are present, and they stay positively with Sudan 3 and oil red O. And morphologically these tumors are of high nuclear grade. So this is a photograph showing these large polygonal vacuolated cytoplasm cells, and this is IHC with adipophilin, which shows positivity for these tumors. Apart from adipophilin, these tumors are also positive for alpha-lactalbumin and EMA. Coming to ERPS status of this tumor, with a very limited data, most of the studies or case reports have shown that ER and PR is negative in these cases. However, HER2 has been reported in up to 50 to 100% of the cases. Then moving ahead with glycogen-rich clear cell carcinomas, here the tumor cells have abundant cytoplasm which contains glycogen, which is fast positive and diastase sensitive on special stains. So this is a photograph showing the cells with abundant clear cytoplasm which contains glycogen, which is fast positive and diastase sensitive. This is the picture showing the same. So it is important for us to know this entity because this form a differential for many of the other rare subtypes like lipid-rich carcinoma, sebaceous carcinoma, and secretory carcinoma. And also many of the myoepithelial tumors can be a differential for this entity because of the clear cells. And also most important thing is we always have to consider metastasis as a differential in a proper clinical context when we are seeing this picture. And coming to immunohistochemistry, these tumors are ER positive in 30 to 50% of cases. However, HER2 status is variable. With the limited data, it is what is known is these tumors are known to follow an aggressive clinical course. Coming to sebaceous carcinoma,